Nice. So I'll talk a little bit about psychedelic medicine, and it's kind of interesting where, Eric's talking about sort of the journey, the military journey. So, what's brought me here is really when you look at sort of the PTSD and the severe depression and the lack of treatment response. And so I get excited just by the idea of something new as a breakthrough. And so I'll start, and my colleague Rob is going to sort of bring us back with some of the more scientific material. So just again, disclosure, I'm the chief medical officer of a biotech firm that's making some medicines in this space, but mitigating, I'm not going to be talking about those, and there'll be no discussion of the off-label use of the medicines. So today we'll talk a little bit about MDMA, psilocybin, medicine-assisted psychotherapy. We're not going to really talk about microdosing in my talk anyway, but that's for another day. And some of the risks, and I think one of the things that we're facing, and it'll be clear by the end of the talk, is that we have a medical model in most of our world of how things are. A patient comes to a waiting room, they walk in, or it's virtual, and this thing turns the whole thing upside down. So I think the question is medicine going to change for the psychedelics, or do psychedelics need to change to fit into the medical model? I think that's part of the question that I think going to have. So the words get very confusing, and when you read and things, and I think the ultimate point is, psychedelics are hallucinogens, so they're psychoactive substances that alter the perception, mood, and affect numerous cognitive processes. And so really the point of this slide, and some people call it, the classical psychedelics, work with serotonin, and LSD, mescaline, psilocybin. You actually have the experience where you sort of altered perception. MDMA is often called a psychedelic, but it's not a traditional psychedelic. It works in a different system, as does ketamine. And so we'll see that sort of confused, and people often use it all as psychedelics, but there are sort of subtle differences, and people have struggled with, do we change the naming, and do we start to change things? And maybe we can discuss that afterwards. The classical psychedelics, there's entactogens. Some people wanted to call them empathogens, so to make you more empathic, which are the MDMA types. Then the dissociative anesthetics like ketamine, cannabinoids, ibogaine. So all of these can cause sort of altered change of perception, and a lot of them have been used sort of in sort of therapeutic settings and things like that, saying basically that altered state might be protective. Oh, just a point, a lot of my slides, drug science is written there. I've kept that in there. Drug science is a group started by David Nutt in the UK, sort of an advocacy and thing, and they have a lot of training materials on cannabis, on all of these. So they just, I'm an advisor to them, so they often say, use the slides, use them. So a lot of the slides are from there. So I purposely didn't remove that because I wanted to sort of be honest about where they come. And Mind Medicine in Australia actually helped produce some of these slides as well. Just very quickly, MDMA, it's chemically related to amphetamine. So it's a little bit different. And that's sort of just simply the point of that slide. Little history about MDMA. There's a lot of details there, but just essentially Merck sort of produced it in 1912, so it's been around since that time. In 27, basically, money was tight. They didn't have the money to keep sort of developing and doing trials. So it came back in 53, 54, some tox studies in animals. They were starting to look at sort of getting it back on the track towards approval. 1960, the first published protocol for MDMA. And in 60, they started to look at things. And then, of course, in the early 70s, the war on drugs started in the US and the world, and sort of the things got outlawed for sort of a long time after that. The Renaissance, which is kind of, Eric just mentioned that we're just on the cusp of FDA approval for an indication for PTSD for MDMA. Basically, this new journey started in 1986. When the MAPS group, Multidisciplinary Association for Psychedelic Studies, Rick Doblin, sort of the founder of this, basically made a commitment to getting this approved, going through the hard and rigorous process of drug approval in most of our countries, which is multiple trials, multiple places, and essentially they're sponsored to 12 completed clinical trials. The phase 3 trials have been completed, submitted to the FDA. And really, in terms of, we're just sort of anxiously waiting to see, how much is a tablet going to cost, right? It's almost, I'd be surprised if it doesn't get approval now. So the physiological effects of MDMA, when somebody is on MDMA, remember that this is not a true psychedelic, so you're going to have, tachycardia, increased blood pressure, hyperthermia. Remember, of course, this is ecstasy that sort of people in raves and parties take, so Overheating is one of the things they always tell kids when they're taking it, to drink lots of water. Sleep disturbance, reduced appetite, some nystagmus, mydriasis, so it affects your eyes a little bit as well. So there are sort of well-known physiological effects that occur. And there are some potential harms as well in terms of tachycardia, arrhythmias. Again, we talked about the hypothermia. There is the risk of serotonergic syndrome as well, so if people are on other meds in particular. Short-term negative mood is also one of the things that's been reported. And one of the interesting things is, and I think Rob will talk about this, is that like the way these drugs are going to be approved, it's going to be for one-time use, two-times use. But realistically, once they're out there, people are going to start using it multiple times. And what's the impact of using it multiple times on these receptor systems? So MDMA-assisted psychotherapy has grown in promise, in a variety of disorders. In particular, post-traumatic stress disorder is the main one that's sort of coming into the limelight. But social anxiety and other comorbid disorders. And I think one of the really interesting things is once we start getting the approval and people start to do it, it's very interesting because of what it creates, that feelings about yourself and your understanding of yourself. People are thinking, could it be helpful in schizophrenia? Could it be helpful in autism disorder? Could it be helpful in some of these other conditions where perception of yourself and others becomes an important part? So actions on the brain, again, just in terms of the serotonergic system. So the positive mood and creative thinking that people sometimes attribute to MDMA. So decreased depression, decreased anxiety, decreased fear, decreased aggression, and increased self-confidence. So those are kind of the core things that people generally attribute to the serotonergic system. Increased dopamine, noradrenaline causes level of alertness, arousal. Remember, it's a bit of an amphetamine kind of thing as well. Conscious registration, and then some calmness and relaxation. And then there's also the empathy and bonding and sort of how you feel about others around you and how you feel about yourself, and that's kind of attributed to the oxytocin release. And when you think about is either therapeutic, from an exposure therapy, from a PTSD perspective, the reduced amygdala causes a reduction in the hypervigilance. The increased oxytocin and prolactin level might cause an increase in trust in a therapeutic alliance. And then the lack of inebriation for most of the experience, because unlike the psychedelics, you are actually, during MDMA, you are still able to be alert and communicate. Your unimpaired memory recall. So the actual experience can be therapeutic in that way. So just very briefly in terms of if people haven't done, like most of these medicine-assisted psychotherapies as we talk about involve sort of multiple phases, and same for the psilocybin, although the substances are different. So the preparatory session ahead of time, which involves educating somebody about the substance they're going to take, the side effects, what to watch for, to understand, build that therapeutic bond with your therapist, who's going to be the person that's going to, or there'll be two therapists that'll sit with you for this protocol with maps, throughout the psychedelic drug session, the experience itself. And they often talk about the set and setting, which is really important, the understanding of why you're there and what you're going to do and what it's going to feel like, and just take away any of the doubts that you have. Then you have the drug session itself, which will involve some discussion, some dialogue, things emerge, and dealing with them they call it a non-directive kind of psychotherapy, which is almost like analysis, just in terms of not like a structured CBT kind of idea. And then several sessions later on for integration, because during the experience and shortly afterwards, the person may be getting more insights about themselves, about the trauma, and to have those integrative sessions helps the people move forward. So the integrative psychotherapy, so the analysis, the psychotherapy can be difficult during the acute phase, but they are still lucid. They're not having a psychedelic or experience. So you can help them make sense. And depending on the set and setting, they know what they're there for. They know they're there for to discuss their traumas. Things will emerge, and therapists will sort of take care of it. And the therapists can sort of frame the experience in the broader perspective to help sort of understand how it went through. So the psychological effects of MDMA, there's an element of euphoria, a sense of well-being, increased sociability, empathy for others, and anxiolysis. And I often talk about empathy for themselves as well. I think it makes that difference because of how somebody feels after they've experienced trauma. So the phase 3 trials, like I've mentioned, they published in Nature, and 3 trials with incredible results. The second one, I lost the clip. That's from a newspaper article. MDMA for PTSD just crushed its face. I think that was the New York Times. I can't remember. And it's the biggest study for this. And after 3 sessions, 67% of participants in the MDMA group no longer qualified for a PTSD diagnosis, and 88% having a clinically meaning reduction in symptoms. So when you think about sort of the results for PTSD overall, normally, 60 to 70% of people still meet the criteria for PTSD after the evidence-based treatment. So this is quite an impressive difference, where you have sort of 2/3 of people, no longer meet criteria. So the opposite of what the treatment as usual is. I'll go a little bit about psilocybin in a similar kind of way, kind of a different substance, or naturally occurs. It's in many types of mushrooms all over the world, and we talked about whether it's in Japan, probably is. We talked about all the different places. But when you look in, ancient art and things, you'll often see mushrooms on the wall, and you'll see drawings from caves from thousands of years ago where people have been using them. There's also, it can be synthesized as well. So there's sort of 2 different ways of doing it. You can extract it from the mushroom, or you can make it synthetically, just like most sort of pharmaceuticals. And it's a 5-HT2A agonist mostly. Again, very busy slide, but just in terms of the history, the renaissance for psilocybin began sort of around the same time, just a little bit after the MDMA, with the Hefner Institute funding studies in UCLA and Johns Hopkins. I think it's interesting, some of the landmark stuff around, I don't know if that's working. Is it working? No? Okay. 2009 through the phase 2. This is some of the work out of Hopkins, where they were looking at the fear of death, anxiety. People that had terminal cancer, they were dying, and the 1 dose of psilocybin helped them. And so in Canada, for example, that's been allowed now for a compassionate use for time being, for people that facing that. In the 2010s, that's when a lot of the studies started to go. So treatment-resistant depression started, and of course the company Compass and Usona are well on their way towards sort of getting that sort of breakthrough status and indication. OCD, our friend Matt Johnston, nicotine dependence, some really amazing results with sort of 1 dose or 2 doses of psilocybin, and really just classic cognitive behavioral therapy has 60-70% smoking reduction, So alcohol dependence, again, it says New Mexico, but also in New York, and anorexia. So again, there is a whole approach with psilocybin that's also quite interesting. It's a prototypical classic psychedelic, and with binding to the 5-HT2A and C, and really has sort of so the perception, the visual changes, euphoria, distorted sense of time. And I think, when you look at this is more like the traditional psychedelic that people are thinking about. And so it's not, while you're having the experience, you're guiding them through it, as opposed to doing therapy while it's happening. So I think it's just important to keep those things apart. So the physiological effects, so again, it's a prodrug that becomes psilocin in the body. So the physiological effects: increased heart rate, pupil dilation, increased gastrointestinal motility. It can be sort of scary for people. There isn't really a toxicity, but the experience itself, so you really need to be prepared for this experience. It's quite different than MDMA. And how it changes, it's been unclear. There's been neuroimaging that shows changes in the default network in different parts of the brain that may enhance learning. And so part of the thinking is that it reduces some of the barriers, some of the inhibitions that you have to talk about, to address some of the difficulties that you have within the world. And so that's kind of the psychotherapy kind of relaxing that sort of rigid defense that somebody may have, because people talk about gaining insights into themselves and the world for months and months afterwards. So something changes in the brain is kind of the thinking of it. And so again, really not too much in terms of toxicity. That's the one thing that people have done. There are adverse effects as transient fear, anxiety, and sometimes panic during the experience itself. There is an increase in heart rate and blood pressure that can occur. It's usually monitored while they're going on. There's the paranoid. And the risk of psychosis. I mean, some of us were talking at lunchtime just in terms of, all of these studies, we've tended to exclude people that have significant mental illness in the past, or, first-degree relatives with schizophrenia, things. So once again we start to use it more widely, we've got to sort of be careful in terms of what we may be unmasking. It's being, again, I mentioned being used for lots of different studies, lots of different indications: anxiety, depression, OCD, eating disorders, addictions, and there's even some medical uses in terms of like intractable cluster headaches and things. So it is really getting more and more popular. Again, very briefly, similar kind of psychotherapy approach. You see the person ahead of time, 14, few days, 2 months before the actual experience. You will do preparatory sessions, set and setting, what to expect, what we're going to be there. Even, we did a protocol once, even telling the person that if you start to wander towards the door, I will touch you on the shoulder and guide you back to your chair in this day of sort of permission and things like that, because they're having their experience. Prepare them for everything that may happen. During the session, again, the difference is that they are going through a very harsh experience, so you're not going to really be talking too much about their trauma or their past. You're going to be more guiding them through it and supporting them through the process. And then the integrative sessions that occur afterwards are the usual parts where you try to make sense of things or new things that may arise with people. In fact, in the Compass protocol, they often they don't really call it even therapy often during the medicine experience. It's more support or guiding people through it. So I'll go back. So the active psilocybin setting, so you've prepared them ahead of time with the set and setting. You'll hear that all the time in this space. So the patient's emotional, cognitive, behavioral sort of mindset and expectations, like what's going to happen, what do you expect to get out of it, just to get them really ready as possible. And the setting tends to be very important, and this is going to be part of my challenge of old medicine, new medicine, because it's often like the type of room, the type of music that's there, the artwork that's on the wall. All of these things tend to be important. And if you're in a university center and you have funding, you can find a room and you can do that. But are we going to do that to our offices? Is everybody going to sort of do this? And so comfortable space, muted lighting, which we talked about, the types of music, even the music that you pick kind of is important in the background. And there's companies that are actually producing playlists now for the psilocybin sessions. And the integrative psychotherapy is really sort of helping people to make sense of what they experienced, i.e. the experience, but they'll gain new insights, they'll gain and help them to work through it. And there's kind of a window that might last maybe a month or so. So some of our studies, we're thinking about doing an accelerated cognitive processing therapy for PTSD after a dose of psilocybin. So the idea is you've got this window after the dose where new learning and new learning is possible. So maybe some of the old therapies might work during that window. So just in terms of, this is sort of an older slide and sort of around the pandemic, but you can just see how many studies are going on. The interventional clinical trials launched, and that's just the US alone, just in terms of the psychedelics. So it really is sort of a growth area where there's a lot of interest. And I'm going to end just with sort of some of my own thoughts as somebody that's relatively new in this space, like 3-4 years, and been looking at it before that. And I just think, I think in terms of, and we'll talk about the things, the half-life, sort of the drug, the nature of the drugs. We've basically been given these drugs and we've kind of adapted a clinical use to it. We didn't design the drug with clinical use in mind, kind of idea. And the long-term safety of the meds, the training needs, and what it's going to do. So I'll just talk about these topics, and then we'll hand it over to Rob. So part of it is that, sorry for this is blurring. I was trying to get a picture of a bored therapist, retired therapist, and so the medicines, whether they last 4 hours, 5 hours, 6 hours, 8 hours, variable onset. It's just the idea of MDMA psychotherapy, you're going to have 2 therapists sitting with somebody for 8 hours, 2 trained therapists for the whole, just in terms of the resources. And I think Eric and I were at the ISTSS a few years ago, and when MAPS was first presenting their results, and some of our colleagues stood up and said, who's ever going to pay for that? Is that realistic? How much resources? And Andy Greenshaw yesterday gave us a nice plenary and talked about health equity. This is the complete other end of the spectrum, right? So maybe the sickest people will get this, that aren't going to respond to other things, but it's going to become an economic issue. Who can afford it? Who's going to use it? So I'm just So do we know that people need 8 hours? Like, and this is where, we've all been part of drug development as drugs have gone. I mean, imagine if the only anesthesia you could get was 8 hours, right? You need your wisdom teeth out for 15 minutes, you need a colonoscopy, but just hang in there for another 8 hours while we do it. So I think there's an aspect of this that's sort of just concerning to me, just in terms of, are we stuck with these, and do we need, or will some people benefit with 1 hour, and maybe you can do a top-up? I mean, just in terms of thinking about that. Maybe group therapy is the way to go. Maybe, have one therapist work with 6-8 people at the same time or something like that. So just in terms of, that's kind of my just concern about what we have for these first drugs that are outside the door. I won't go into too much detail here, but I think Rob's going to talk a little bit about just sort of the known cardiovascular risk effects. I mean, there's valve problems, there's hypertension, there's pulmonary arterial, and it's one of those interesting things where, on one hand, the drugs have been used in the recreational world forever, and kids have been using it, but it's another thing when we are prescribing it and what happens there. So I just think in terms of, and part of the risk, I mean, the FDA put a warning out last year about some of the cardiovascular things, but I think the concern that I have, like I've said, is, the indication is going to be for 1-2 doses, but what happens when the depression recurs 6 months later, just like with ECT, just like with other things that we do. Also, the whole microdosing piece, people are using it sort of continuously. So I just think we need to sort of continue to think about safer drugs while we're at it. And the training needs, I think, becomes interesting. Just today, somebody's proposing an MDMA sort of trial sort of in Canada for veterans. And I just think in terms of, right now, for example, there aren't enough trained therapists, but the trained therapists are largely being trained within these large trials that are funded by the corporations, and it's not really in academia yet. There are centers for psychedelics in all the universities, but your PhD psychology student isn't being trained in psychotherapy for the psychedelics within that university setting. So I think in terms of things, for some of us that have been around, it takes me back to the old EMDR days where it was controlled very much by the company, and so it's kind of, that's going to make it difficult. I've done the training for the the MDMA, and it was online because it was during the pandemic, but many hours of training, many hours of this, and so the question is that we're going to end up having a need care gap in terms of shortness of therapists, and it takes quite a while to get the training. And then the other thing, like just very very practically, like if I'm happy in my office in Toronto or Amsterdam or Dublin, and I've got my office, my traditional doctor's office, am I going to break down the wall next door and make a special space for the psychedelic medicine with a couch and special speakers and artwork and all this stuff? So I just think in terms of are we going to completely change practice, or are there going to be ways of sort of integrating this, and these sound practical and logistical kind of things, but they will need to be overcome because people aren't going to change just for the sake of change. So I think in terms of where things go, I mean, in an ideal world for me, it would be, psilocybin has a 10-minute onset. The patient can take it in the waiting room while waiting, with a bottle of water, come in, have an hour-long session, it wears off, they go, they relax, they take an Uber home, right? That would be the kind of thing where the medicine would start fitting our practice more than this. And I think, and I hear that a lot from colleagues, just in terms of like just the impracticality of it once it gets into the real world. So that's going to be the other challenge and the other half-life and cost and all of those are related to that. And you can treat more people if you had those changes. I think I'm going to stop there, Eric. So.